about dentist lab communication. And by the way, this is one of the competencies that you have to graduate with. As a dentist, you need to know how to communicate with the lab. It's misfortunate that you don't get to do your lab work anymore. So that doesn't mean that you don't need to know what you need to know. You have to know how to speak with the lab. You have to know how to make decisions and choices, and you have to know that you're giving the lab all the information that they need for each restoration. Each restoration may be different, so you have to know when you need what. Well, you almost always, if you're doing a porcelain fused to metal crown or a ceramic restoration of any sort, of course, we need the shade. We all know that. So, and I did mention last time that I posted the self-study shade material. There's a video and some slides that tell you what value is, what hue is, and what chroma is. These are typical board questions, by the way, whether it's the 8X or an integrated board or an exam. I mean, the questions about the value, the chroma, the hue always come up. Who can tell me the most important element of color? Is it hue, value, or chroma? Value. Thank you. Yes, thank you. The value is the most important. Why? Because the human eye is trained best to pick up a color mismatch in terms of grayness. So if something is more gray or darker or brighter, your eye will pick it up faster. And to help your eye pick up the value when you're doing a shade match, all you have to do is what? Who knows the answer? What do you do with your eyes when you're trying to pick up the value when you're doing a shade match?
Close one eye.
Good guess. Yeah. No.
You
squint
squint.
Yes, you squint. By squinting, you activate the rods in the retina, which are wired to pick up the value of the color that you're looking at. And since the value, if your value is off, everybody can see it. If you're slightly off with the chroma, the amount of saturation, or the hue, the nature of the color, you might get away with it. But if you're off with the value, you will not get away with it because everybody will be able to see, oh, this crown is darker, or this crown is lighter, or is brighter. So it's how gray is that restoration. Squint your eyes when you're doing the shade selection, and remember to stick loud every time you squint your eyes for a shade selection. All right, so we talked about the final shade of the restoration. And when you tell your lab, I want my final restoration to be an A1 or a C2 or a C3, you have to know that what's going to contribute to that ceramic restoration. Most importantly, really, if you're dealing with a translucent restoration, is the stump shade. And I spoke about this last time. And I told you that this is the same exact veneer, but it happens to be sitting on a die here made out of a yellow stone, as you can see. And look how much of that yellow is coming through. Well, of course, you have a translucent restoration is a more accurate term. So you have a translucent ceramic, and the color of the subject underneath it's going to come through. So when we make aesthetic all ceramic restorations that are translucent, or transparent, we always have to pick the shade of the underlying tooth preparation, which we refer to as stump shade or natural dye shade. And I was mentioning last time is that in the lab, they have a resin material that corresponds to these ND shade guides. So when the lab technician is doing a veneer for you and you told them that the stump shade is ND4, what they do is they have the veneer made out of a ceramic material that is compatible to give you the final desired shade, but they make resin dyes, and the resin they choose has the same shade of the ND shade guide. So this shade guide here comes with a matching resin material, not for you to use, for the lab to make a resin dye and put the veneer on it when they are characterizing it and see, am I giving the dentist the same shade that they wanted based on the stump shade? So I cannot emphasize the importance of the underlying stump or the color of the underlying tooth structure. The next thing you want to understand, and I also talked about this last week, is you have to know that if you're trying to do major color correction, you need additional clearance for a layered restoration. this happens to be lithium disilicate or Emax, we can all appreciate that this is a very dark stump shade, very dark color. And look how beautiful this tooth is. Now, who can tell me? It's a yes, no answer. In order to block this tooth color, I need a very opaque ceramic. Yes or no?
Yes.
Yes. Yes. Okay. Is an opaque ceramic going to give me a beautiful translucent outcome like to match the adjacent tooth? Yes or no?
No.
No.
Absolutely.
No.
So, how do you get both effects? How do you block out the underlying opaque ceramic and still have a translucent, beautiful outcome? What do you have to do?
Coping.
Layering.
Yes, coping layering. Yes, 100%. You have to do a coping of an opaque ceramic that will block the underlying discolored tooth structure. And then you have to do layering on top of that using aesthetic, beautiful, translucent ceramic to capture that final aesthetic outcome. So congratulations to to you who answered, because I hope everybody understands the concept of sometimes we need a layered restoration, because sometimes you're trying to achieve too much and sometimes one ceramic is not going to give you what you're trying to achieve. So ceramics like Emax or lithium disilicate is a very diverse ceramic system, very versatile. It gives you a lot of options. It comes in multiple levels of translucency. So it comes in high translucency, low translucency, medium opacity, and high opacity. And in here you see a 1 millimeter disc of the ceramic transposed over as you can see, like a Sharpie marker. And you can see that the more opaque ceramic will not show through a discolored tooth structure. So going back to what we just talked about, the manufacturer really gives all the technicians a chart of what they can use and when. So they tell them, the high opacity ceramic is not beautiful to be used as a standalone restoration. You cannot do a monolithic restoration from this high opacity or medium opacity because they're too opaque, they're too ugly. So you can only use them for coping with a layering technique. You don't have to know the details of this chart, but if you're going to practice as a clinician, you have to know that these options are out there, and at least you have to know what kind of information you need to give to your patients. So, Jenna, are you with us?
Yes, I'm here.
Okay, I'm going to ask the question, you're going to answer. How is that?
Okay.
Kind of weird, but whatever, we'll just do it. Okay, so is it important that I know if my Emax crown will be layered or not?
Yes, because if it needs to be layered, you need to provide greater than 1 millimeter facial reduction, around 1.3.
Okay, I will stop here. Why do I need, or maybe Jenna, you can answer, why do I need more reduction if I'm doing a layered restoration?
Sorry, I muted myself. So
Oh.
the ceramic isn't so thin?
Yeah, so because you need two layers of two things.
One of them will be really thin and chip away.
Yes, so in order to achieve what you're trying to achieve, block the discolored tooth structure, you need at least 0.8 millimeters of the ceramic or 0.7 millimeters of the opaque ceramic, and this will give you enough thickness to block the discolored tooth structure. On top of that, you need another 0.7 millimeters of that aesthetic ceramic to layer on top and create that aesthetic appearance. So I will say about 1.5 millimeters, if you guys can take note. I prefer, anywhere between 1.3 to 1.5 millimeters is going to be a lot of facial reduction. And I want to go back to this picture. And we all agree that this tooth, the reduction is excessive. I mean, it's a lot of reduction. But this person did not just do it based on nothing. They needed more facial reduction. They needed more thickness of restorative material because they knew with how much color correction is needed, they will need a layered restoration. And for a layered restoration, you need more thickness to allow each layer to do the job that it's intended to do. All right, so going back, yes.
Sorry, can you go back to that photo? I just starting off, what causes like that stump to look so different from the other teeth? Is it like a genetic thing that
So I do not know what happened in this particular picture, but it could be that the tooth is non-vital. It could be that this tooth had trauma, and maybe they should have tried intrinsic if it's root canal treated. Maybe they should have done some intrinsic bleaching or internal bleaching, but people worry about root resorption. So I do not know what happened there, but most likely it's a history of trauma. Um, Unfortunately. But I agree, it's a very stark difference between the two colors. Most likely, it's going to be a history of trauma and non-vitality of the tooth. So, Jana, we go back to our awkward conversation here. How do I know if my Emax crown will need to be layered? So, you are preparing a tooth in the clinic, and now Dr. Kablawi told us that if it's going to be layered, I need 1.5 millimeters, not 1 millimeter if I'm using Emax. How do I know? Go ahead, Jana.
Depending on the stump, the ND shade, the final desired shade, and referring to the chart on the following slide. If the chart indicates the need for an MO, a medium opacity, or an HO, a high opacity, then the restoration must be layered. A restoration made fully of medium or high opacity material will look too opaque and far from natural.
Thank you. So this is the chart that you have to memorize for the final exam, and don't freak out. It's very easy. It takes about 2 weeks to memorize. So with all the time you guys have on your hand, I'm sure it's not going to be a problem. What do you think? You want to give me a thumbs up? Can you do it? Or a thumbs down? If you don't want to memorize it, just give me a thumbs down and we will cancel. Oh my God. Okay, Laurent just threw all of you under the bus. He said, yes, we are going to memorize it. Oh my God, I'm getting thumbs up. All right, okay, no. All right, we go back. Okay, no, we will not memorize it. Don't even worry about this. And these things change every day, but this tells you what we're looking at. So the lab has access, and basically, if the lab is working with a case like the crown that we just looked at, and they say the final desired shade is A1 here, and the stump shade is ND9, is very dark, then I have to use a high opacity ceramic, lithium disilicate ceramic. If I'm using high opacity, can I make the full crown out of high opacity? We just said, no, you can't. It's going to look too ugly. So I have to do a layered restoration. So depending on the underlying color and the final desired color, the manufacturer gives the lab an idea of what kind of ceramic, how opaque the ceramic needs to be. If they need to use a very opaque ceramic, it has to be a layered restoration. I hope this really explains what we have been discussing. But just to make your life easier, to give you a quick way to determine if you are on the lower end of the stump shade guide. So if you're dealing with a tooth preparation that is light in color, you probably don't need to layer. You probably are okay using a monolithic translucent ceramic because the color underneath it is pretty and the lab will be able to give you a nice outcome. But most likely, if you are on the other spectrum of the stump shade, if you're dealing with a dark tooth and you're looking to give the patient a final light color, then most likely you're dealing with a layered restoration, and with that you will have to provide more reduction and more clearance. So I hope this is clear so far, and go ahead and let me know if you understand the concept of layered restorations. All right, that is wonderful. I got a majority of yes and 97%. I'll be happy to discuss further with anybody who has any questions, and we can make arrangements for outside class time. But I'll first invite you to review the slides and let me know if you still have any questions, and happy to discuss further. This is the crown that we were looking at, and this is in stump shade number 9. The final desired shade is A1. And what happens is the lab will create that opaque substructure, and this is the final outcome. Voila. Now this is a fully layered restoration. It's called layered lithium disilicate restoration. Sometimes we have to do it. It is not as strong as the monolithic lithium disilicate because the layering ceramic is really feldspathic, but it is strong enough. in patients who do not have parafunctional habits. This is a restoration in the anterior area. Patients are supposed to know that this crown is not made of metal, and ceramics are brittle in general. They can still consume everything they can, but they just need to know that this is a ceramic restoration. Going back to our responsibilities, you have to know, and your patient needs to understand, that major color correction cannot be achieved with veneers. So when I tell you that this is just a simple veneer case, is this reasonable for a veneer case to go from the top picture to the bottom picture? Go ahead and give me a thumbs up if you think that's reasonable. Okay, yes, good. I'm seeing mostly thumbs up, which is great. Wonderful. Going back to our picture. Yes, it is, because we do veneers. You have symmetrical gingival margins. The colors are not terrible. Yes, this is something reasonable. Look at the ND shade you're dealing with, not so discolored stumps. Yes, it's doable. But when you're dealing with that, you can use Empress veneers, you can use Empress CAD or Empress Press. But this is a case that was really, this must have happened, I don't know, maybe 12, 13 years ago. This is a picture with an iPhone with a faculty who was preparing a veneer, and they sent me that picture and they said, this is ND8, can we do a veneer? And they're trying to get a final restoration that is A1. And looking back at our slide, if you go to an A1 right here and you're looking at ND9, the suggestion is you can only block out that discolored 2 structure with a high opacity ceramic. Can I do a veneer with a high opacity ceramic? Absolutely not. So just to know that you cannot do much color correction with veneers. For a patient like that, maybe you want to try some bleaching and see how far you can get, and then explain to this patient that you can only offer slight color correction if you're doing veneers. So if I'm going to be conservative and only remove the bare minimum of enamel and give you veneers, there's no way I can offer you a bleach shade. If you want to go with something that is an A1 or a bleach shade, then we have to do full coverage restorations, because I have to do a layered restoration, unless you want to look like, those chiclet smiles, right? Say, I have a better, yeah. Like, who would like these veneers in their own mouth? Let's do the thumbs up one more time. Give me a thumbs up or thumbs down or no. Would you like those veneers in your own mouth? Well, some people do, but of course not. You're not going to put this in your patient's mouth. This is a very opaque veneer, right? I mean, if you're looking to block a very discolored 2 structure with a thin veneer, your veneer is going to look like chiclets, just like that. So nothing that any of us would want to put in our patients, right? So let's go back and see what I missed.
Dr. Koblawi, can I ask you a quick question?
Of course.
So I've heard a lot in the media about flippers or the fake teeth. How does that work? Because I know they're removable, so I was just curious.
Yeah, of course. So a flicker is the interim denture, really. A flipper is, we don't use these terms with our patients, because if you tell them a temporary denture or a flipper, they're not gonna even want to pay for it. So a flipper is really an interim denture. So if a patient comes in, they lost a couple teeth, and in the process of fabricating more definitive kind of restoration, you make them a cheap interim temporary kind of removable appliance. So it's like a complete denture, but it's a partial resin-based denture that doesn't have a metal framework. So it's just like an interim partial denture that is made out of resin. That's all that they just pop in their mouth, and normally it covers the palate. It engages few undercuts, in interproximally, like it extends interproximally in the papilla between the teeth, and this is how it is retentive. Some guide planes and some friction against the teeth. So that's it. Anything else?
Nope, thank you.
You're very welcome. All right, so we're talking about the shade of the final restoration. If you're a patient in the chair with high aesthetic demands and they want a final restoration with the shade of A1, then you better know that you have lined all your ducks in a row to make sure that you're going to get that final desired shade. We talked about the stump shade and we are not going to ignore that anymore. But what else can affect the final shade of the restoration? How thick your restoration is. So again, if you're trying to block out some discoloration on the tooth, the thicker the restoration, the more capable it is of blocking out that discoloration. What kind of ceramic you're using, how translucent is that ceramic, and what is the shade of that ceramic. This is really something for the lab to figure out. And as you have seen in that big exhaustive chart that I will test you on the final exam, is all these options. So depending on the desired shade and depending on the stump, the lab technician is gonna choose the shade and translucency of the ceramic that is most apt to give them a final desired shade. And then finally, the cement shade. Remember that if you're dealing with a translucent restoration, the shade of the cement can also show through that translucent ceramic. But what do I mean with that shrinking effect of the shade cement? I'm just trying to tell you, don't count on that. It's really a minimal effect because the cement is going to be, in this case, obviously a resin cement, comes to a very thin layer. So don't count on massive changes of the final shade with the resin cement. So if you're dealing with an aesthetic restoration in the aesthetic zone, you are most likely going to be using an aesthetic resin cement. And why is it called an aesthetic resin cement? Well, for two reasons. First, it comes with multiple shades that can offer you some slight final correction to the color of the restoration. But more importantly, they come with a matching try-in paste. This is another important concept, so please, please, please pay attention. We're going to talk about the importance of using the try-in paste as an optical connector. But first, those resin cements, they come in a whole variety of forms and delivery forms and shades and shapes and whatnot. For example, what we use currently is the Variolink Aesthetic, which comes in a dual cure mode where you have a base and catalyst. And you have also a light cure mode where you only have a base, meaning if you use the cement, you better know that you can get the light to every part of that cement so it will polymerize adequately. But if you think your restoration is a bit too thick in some areas, or if these are crowns and you have the interproximal area and you're not sure that the light can get through to the cement, then go ahead and use a dual cure cement. You will learn down the road in this course that even if you're using a dual cure cement, you must polymerize the cement with light. A dual cure cement is not engineered to fully polymerize without the cement. I'm gonna cover this when I speak about cements, but just I'm planting a seed here, is that even if you use a dual cure cement, you must light polymerize it. But in areas where you feel maybe the light didn't get through to that spot, it's going to be okay because the dual cure capability is going to take over. But dual cure cements must be kick-started with a light cure. So you have to use a light unit to polymerize both. So the shade concept that is part of the Variolink, gives us a different shading system. You would use the neutral if you don't need any color correction, which means you tried in your restoration that came back from the lab. Let me go back here for a second. In this kit, underneath the cement, there is a try-in cement. A try-in cement is a cement you can apply to the restoration and put it in the mouth and see the final result before you actually cement the restoration. You will learn that having the air between the restoration and the tooth prevents you from seeing the truthful final outcome. And that's why we need to use a try-in paste. So if your restoration looks great, you take the try-in paste, maybe the neutral, and you apply it to the inside of the restoration. You set it on the tooth and you look at it. And if it looks wonderful, then you go ahead and use the neutral cement from this aesthetic cement. The neutral is normally also called transparent or translucent, meaning that it's not going to do any color correction. But if you try in your restoration with a neutral try and paste and you say, you know what, it seems a little bit too dark, I would like to lighten it a bit or lighten it a bit more. So you have a try and paste and you go with the light try and paste or the light plus, or you say, I want to add a little bit more warmth to it. So you start going into more chroma and lower value in this direction. I want to make clear that every cement system has its own coloring system, its own nomenclature. This happens to be Variolink, which is from Ivoclar Vivadent, which we carry here at the school. But you know, you need to know which cement system, which aesthetic resin cement system you will be using when you graduate, and make sure that you know their coloring system. So this is the matching try and paste, and it is an optical connector. And I share with you one of my own experiments to highlight the importance of using a try and paste as an optical connector. So I did a veneer preparation of this discolored tooth, and I wanted the final shade to be an A1, right? And I fabricated the veneer in an A1, and you know, I'm looking at it and it seems like it looks good, right? I mean, at an initial look, it seems to me that the shade matches very well. So I say, wow, this looks great. I'm just going to use a transparent cement. I'm going to cement it with a transparent cement because I don't need any color correction. So let's see what happened when I use the color correction. Who can go ahead and squint your eyes and tell me what you see? Who can tell me? It looks darker, it looks grayer. Absolutely. So what happened? Why did the appearance of this veneer changed when I put in the cement? Because there was no optical connector. When I put in my veneer on the tooth here, there was air between the veneer and the tooth, and the air can deflect and diffract the light, that it doesn't really show me what I'm going to see when there's a material between the tooth and the veneer. So the try and paste is meant to fill in that gap and act as an optical connector to allow the light to go through, capture the color of the tooth, and come back and show you exactly the final outcome. So on the first picture, when you look here, if you do not use a try and paste, you will be fooled into using a transparent cement, and this will be the outcome. And you're gonna call the company and tell them, hey, I cemented the veneer, it was perfect, but the cement turned gray after I cemented it. And they're going to tell you, wait a minute, when you tried it in, did you use a try and paste? And you say, no, but it looked great. Well, yeah, it looked great, but you didn't really get a truthful picture of what it was going to look like. So please, 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 I hope you appreciate the importance of using a try and paste. So I wasn't silly enough to cement it in this case. I really was using a try and paste here. So I used a transparent try and paste, and I realized that it really looked too dark. So I said, I want to improve the brightness, and I used a lighter cement, and I was able to correct that slight issue. So this is a real example that I have done just to demonstrate the importance of the try and paste.
Dr. Kablawi,
Yes.
do you mostly do this just for like thinner restorations like veneers, or would you do this in the case of full coverage also?
A good question. Good question. So if you have a full coverage restoration that is 1 millimeter thick, made out of lithium disilicate, so it's a monolithic, which means that it's going to be transparent to translucent. Why do I keep messing the terms up? It is going to be translucent. So yes, anything in the aesthetic zone that is translucent. So if you're doing zirconia restoration, ideally we should not be doing that in the aesthetic zone. But if it's a layered restoration, it's not going to matter because there's an opaque coping. So the color of the tooth is not going to show through. The color of the cement is not going to show through. Zirconia, we're not seeing much, and zirconia is not applied much in the aesthetic zone. So my answer to you, Jenna, is I would use it anywhere in the aesthetic zone when I am using a translucent restoration. So this can be a veneer, it can be a crown made out of medium translucency or low translucency or medium translucency or high translucency lithium disilicate. So anything that is not layered with an opaque coping, anything that is not zirconia, anything that is translucent, I would use that.
Thank you.
Of course. Keep in mind that the try and paste corresponds to the shade of the polymerized cement. So it's very accurately designed by the manufacturers. So what about monolithic zirconia? Zirconia is not translucent. So this is just an idea of how much you can see through it. So at 1 millimeter thickness, you barely see through it. And with that, you probably don't need a try and paste. You probably don't need to worry much about the shade of the stump. However, this is changing by the minute, meaning newer zirconia formulations are made to be more translucent. So please get to know the zirconia that you're using. If your lab is offering you zirconia, ask them, how translucent is it? Oh, should I use a try-and paste? Oh, should I worry about the stump shade? Now you know what these are and how important they are, right? So this is the shade concept with zirconia, just so you know that zirconia is opaque, but it comes in different shades. Just example of the shading system. But again, like I put this slide together maybe last year, probably things changed already. Things continue to change. You don't really need to know that. You just need to understand the concept that different materials have different translucency. When you're working with all ceramic restorations, we're wrapping up all ceramic restorations. So you're working with all ceramic restorations and you need to use a fit checker. And I know that you've used the fit checker, the disclosing medium in the B30 as a D2. For metal-based restoration, we have a white fit checker, and the white fit checker helps us to see any areas of burn through that need to be adjusted for the crown to fully seat. So with all ceramic restoration, a white fit checker is not going to be very helpful, and that's why we have a black, and even better, we have a blue fit checker now in our clinic that comes in a like in a dual syringe. So it's like a PBS cartridge. You just load it in a gun and you can inject it directly into your crown. It's dark blue in color. It's a disclosing medium to help you identify any areas of interference that are preventing the crown from seating all the way. Just because the white fit checker is not going to show you anything on a white restoration. So, I mean, in conclusion, with all ceramic restorations, it's all about making sure that everything is accounted for. Yeah, for some reason, it's not finding the media, so I'm just gonna skip through this video. And we start talking about failures of all ceramic restorations. You know, it's good to be successful. We've lined up all the criteria that you need to have in place to have a successful restoration, but failures do happen. And just before we start talking about failures, just a quick reminder about contraindications to all ceramic restorations. Remember that patients with parafunctional habits are contraindicated for the use of glass ceramic restoration. That includes lithium disilicate, which is the strongest glass ceramic out there. It seems like gold crowns remain to be the gold standard for patients with parafunctional habits, but zirconia was introduced really to say that, you know, strong enough and it can be used for patients with parafunctional habits. My recommendation, if you're working with a patient with parafunctional habits, make sure that you give them a night guard at the conclusion of their treatment, because that can help deflect those forces and make sure that the pressure, the load is shared on the entire occlusal units rather than just delivered to one particular tooth on one restoration. We have looked at Dr. Goodacre's paper before where it discusses complications in fixed prosthodontics, right? So now he talks about complications of all ceramic restorations. And as you can imagine, the most common complication in a single crown, as you remember, was the need for endodontic treatment, followed by porcelain fracture. But when you look at the most common complication in all ceramic crowns, then the first answer is fracture. So this is a typical board question, and it's really it's annoying because board questions are almost always outdated, right? So fracture might not be the most common complication of all ceramic restorations anymore. I have the attendance poll. If you want to take a second and let me know that you're here. Okay. I'm gonna switch it off. There you go. Thank you, guys. So this was published in 2003. So back then, we only had weaker all ceramic restorations, and it does make sense that fracture was the most common complication. Unfortunately, if we're asked on the board, we still answer that fracture is the most common complication. But it's also important to look at newer literature, and newer literature looked at stronger ceramics than what was addressed in Dr. Goodacre's paper. And this is a wonderful study that reports on the 15-year survival of bonded lucite reinforced all ceramic restorations. And the survival rate was in the range of 70%. Who remembers the brand name? Oh, it's IPS Empress. It's right there in front of you. You know why this is a very cool study? Because Empress is still on the market. And most of the time, by the time we have 15-year clinical data, the material is no longer on the market. So to have 15-year survival data for a material that is still currently used is very special. In this paper, though, although we all know that Empress is not as strong as Emax, the most common reason for failure was loss of restoration, meaning the restoration was coming loose or, debonding. And then crown fracture was the second most observed complication. So what I'm trying to say is that as we have more stronger all ceramic restorations right now, fracture may not be the first or the most common failure. Perhaps some other things become the weaker link, and in this case, maybe restorations are debonding more than fracturing if they're under excessive forces. In this paper, they also reported 3 significant predictors for failure of the restorations. Gender, where they found more failures in males, and more failure in patients with parafunctional habits, and more failures on non-vital teeth, right? It seems like all these factors are patient-related rather than material-related. So I share with you briefly some of the trends pertaining to failures with all ceramic restorations. And it seems like debonding is one of the most common failures, followed by fracture, discoloration, and sensitivity. So let's talk about debonding. Jenna, you want to help me out with this slide? Here. Thank you.
The introduction of stronger all ceramic restorative materials have resulted in a shift of failures from ceramic fracture to debonding. Proper diagnosis of possible causes for debonding should be achieved before the restoration re-luted into place. Improving the quality of the cemented interface may contribute to higher success rate in all ceramic restorations.
Thank you so much. So, the second statement here is extremely important, not only with all ceramic. If a patient shows up with a debonded restoration, before putting it back, you want to ask yourself, why did it come off? Is it retention resistance form? Is it occlusion? Is it something else? So troubleshoot and make sure you identify the reason, eliminate the reason so you can address the reason rather than just treating the symptom.